Good morning, everybody. Myself, Dr. Khondokar Monirul Alam. I am working as a consultant in the Department of Gastroenterology, Rampur Medical College Hospital, Rampur. Today, I will discuss regarding the update management of NASH. We know as the economy is growing, especially in the third world country, our metabolic syndrome is also growing in the general population. So, what is metabolic syndrome? WHO criteria for Asia Pacific region is defined by diabetes mellitus, impaired glucose regulation, and or insulin resistance with two or more of the following criteria like that central obesity, hypertriglyceridemia and or low level of HDL, raised blood pressure and microalbuminuria. And revise ATP3 criteria for Asian population. Metabolic syndrome is defined by any three of the following: central obesity, hypertriglyceridemia, low HDL level, raised blood pressure, raised fasting plasma glucose level, that is more than 5.6 millimole per liter. Now, Asia Pacific Working Party on Non-Alcoholic Fatty Liver Disease 2006, what they say? Asian definition of metabolic syndrome must have any three or more of the following criteria. First one is central obesity, which is further defined by waist circumference more than 90 centimeter in case of male and 80 centimeter in case of female, and or BMI more than 25 kg per meter square in both sexes. Another criteria is hypertriglyceridemia, which is more than 150 milligram per deciliter in both sexes, and low level of HDL, that is less than 40 milligram per deciliter in case of male and less than 50 milligram per deciliter in case of female, and high blood pressure, which is defined by more than 130 millimeter of mercury by 85 millimeter mercury is defined as a part of metabolic syndrome, and the fasting blood glucose, which is more than 5.6 millimole per liter or previously diagnosed type 2 diabetes mellitus. So we are in the era of non-alcoholic fatty liver disease. Initially, people work for their food and for their survival, but in the advancement of the economy and the technology, people became more life became more easier, and in modern days human became more obese and fatty. Now metabolic syndrome and non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease is closely associated with the amount of the fat in the liver and the muscle tissue, and the three of impaired fasting blood glucose level or type 2 diabetes mellitus, hypertriglyceridemia, low level of HDL, increased waist circumference, and high blood pressure, which I have already mentioned in my previous slides. Common related metabolic disorders associated with type 2 diabetes mellitus, irrespective of liver enzymes, diabetes risks and type 2 diabetes mellitus are closely associated with severity of the non-alcoholic fatty liver disease, progression to NASH, presence of advanced fibrosis, and development of hepatocellular carcinoma. BMI and waist circumference are positively related to non-alcoholic fatty liver disease, and which is a predictor of advanced liver disease and particularly in the elderly population. Now the definition of non-alcoholic fatty liver disease. For defining non-alcoholic fatty liver disease, there must be evidence of hepatic steatosis either by imaging or by histology, and lack of secondary causes of hepatic fat accumulation. So, before diagnosis non-alcoholic fatty liver disease, there must be evidence of hepatic steatosis, that is, accumulation of fat in the liver, which will be diagnosed by further imaging, that is ultrasound or fibroscan, and histology. Now, Histological category of non-alcoholic fatty liver disease is first one is non-alcoholic fatty liver and second one is non-alcoholic steatohepatitis. What is that? Non-alcoholic fatty liver is defined as the presence of 5% of hepatic steatosis without evidence of hepatocellular injury in the form of hepatocyte ballooning, that is accumulation of fat in the liver cell 5% without any evidence of liver injury in the form of hepatocyte ballooning. Now the NASH is defined as the presence of 5% hepatic steatosis and inflammation with hepatocyte injury, that is ballooning with or without any fibrosis. That is, here in the NASH the presence of fat is 5% associated with inflammation and hepatocyte injury, which is absent in case of non-alcoholic fatty liver. Now the global prevalence of non-alcoholic fatty liver is variable and correlates with obesity. Here the picture showing the different percentage according to the area in different uh, area in the world. What about in Bangladesh? Almost 34.34% population is suffering from the non-alcoholic fatty liver disease in Bangladesh. This is the Bangladesh scenario, which is worsening day by day, and it is mostly happening in the urban area. Now, the pathophysiology. First picture showing the normal liver, and the second picture showing the steatosis, that is fatty liver with trivial or no inflammation and no hepatocyte ballooning. And third picture showing steatohepatitis, that is NASH, in which there is fatty liver with significant inflammation of the liver cell and ballooning, and it is 3 to 4% of the non-alcoholic fatty liver. And finally the cirrhosis, that is increasing fibrosis leading to cirrhosis and hepatocellular carcinoma, and is 1 to 2% of the steatohepatitis. This is the natural history of the non-alcoholic fatty liver. Initially, it is categorized into two types, that is one is NASH and another is non-NASH. And 25 to 35% of the NASH patient progress to the fibrosis, and 9 to 10-20% population of fibrosis turn into cirrhosis. And all the among the cirrhotic patient, 40 to 60% population within 5 to 7 years turn into the liver failure. And finally, the death or liver transplant needs in 22 to 33% population. And among the cirrhotic patient, 10% population over the 7 years become the patient of hepatocellular carcinoma. And some other risk factors associated with non-alcoholic fatty liver disease, which I have already mentioned, that is diabetes mellitus, obesity, dyslipidemia, other component of metabolic syndrome, polycystic ovarian syndrome, hypothyroidism, obstructive sleep apnea, hypopituitarism, hypogonadism, and psoriasis, and so on. Now, the risk factors of non-alcoholic fatty liver disease according to Adult Treatment Panel 3, that is a waist circumference greater than 102 centimeter in men or greater than 88 centimeter in women, and a triglyceride level greater than or equal more than 150 milligram per deciliter, a high density lipoprotein cholesterol level less than 40 milligram per deciliter in case of men and 50 milligram deciliter in case of women, a systolic blood pressure greater than 130 millimeter mercury and diastolic blood pressure greater or equal than 85 millimeter mercury, a fasting plasma glucose level greater or equal more than 110 milligram per deciliter. All other features risk factors for non-alcoholic fatty liver disease, but the three or more criteria when it is fulfilled, then it is uh, called the metabolic syndrome. Now the presentation, regarding presentation, usually it is an asymptomatic disease, majority discovered by chance, that is on routine sonography or routine cholesterol level. Patient may present with fatigue and right upper quadrant discomfort, and often as an incidental finding. Incidental abnormality may be found on liver function test incidental bright liver on imaging, that is on ultrasonogram. And the common scenario is when any medical insurance and occupational health checkup, that patient goes through the routine checkup and found that he or she is suffering from the non-alcoholic fatty liver disease. In Bangladesh perspective, non-alcoholic fatty liver disease is coming as an epidemic, as a as we have higher incidence of the diabetes mellitus and obesity, and rapid socioeconomic development changes in dietary habit also. These are the global scenario, I have already mentioned earlier, and there is a relationship between fatty liver and insulin resistance, and the main pathophysiology is excess accumulation of fatty acid, and finally there are some endocrinopathy, and finally insulin resistance become occur. So there is a vicious cycle between the excess accumulation of fat and the insulin resistance. And this is the graphical presentation of obesity, excess calorie intake and excess fat, and finally become the excess amount of the free fatty acid, and finally the non-alcoholic fatty liver disease. And this is a picture showing how a normal liver become diseased liver by increased accumulation of fat, which I have already mentioned. Now, the first step in suspected non-alcoholic fatty liver disease, we should first assess the risk identification. That is, patient has type 2 diabetes mellitus or not, patient has metabolic syndrome or not, and first degree relatives is suffering from the non-alcoholic fatty liver disease or cirrhosis or HCC. Regarding history, is there any history of the alcohol intake which is more than the standard level, that is more than 40 in case of female and more than 21 drinks in case of male in week. No one pre-existing liver disease, not known any pre-existing liver disease, and some investigation we must do, that is liver biochemistry, LT, AST and other investigations, and we must exclude other liver disease, coexisting liver disease like hepatitis B and C serology. And for the autoimmune liver disease, we must search for the ANA, AMA, SMA, LKM1 and ANCA, negative celiac serology, and normal immunoglobulins, ferritin, and copper level, etc. And liver ultrasound increase echogenicity, that is statosis. These are the investigation we should initially first do any suspected case of non-alcoholic fatty liver disease to exclude the other causes of the liver disease before diagnosis as a case of non-alcoholic fatty liver disease. Now the liver enzymes, ALT can be normal in more than 50% of the population with NASH and 80% of individuals with non-alcoholic fatty liver disease. It is very much interesting. And ALT can be elevated in 50% of the individuals with non-alcoholic fatty liver disease but without any NASH. In non-alcoholic fatty liver disease, ALT is neither indicative nor predictive of NASH or fibrosis stage. Normal ALT does not preclude NASH and progression of the disease, and elevated ALT cannot predict the further fibrosis. ALT or AST not a sensitive test for non-alcoholic fatty liver disease or NASH. The summary is ALT can be normal, but patient have NASH, and ALT can be elevated, but patient does not have any NASH. This is the message. Now, the ultrasound criteria of the fatty liver disease, as we all know, this is the most simple but powerful tool for the diagnosis of the fatty liver disease. So, when we call a case of mild fatty liver disease, when minimal diffuse increase in the liver echogenicity, and when it is moderate, that moderate diffuse increase in the echogenicity, slightly impaired visualization of the intrahepatic vessels and diaphragm. Whenever we go for a ultrasound, that the sonologist could not find out normally the intrahepatic vessels and diaphragm, that in that case we should call it as a moderate case of fatty liver disease. And when it is severe, marked increase in echogenicity and poor penetration of the posterior lobe, sonologist cannot see the posterior part of the liver, and poor or no visualization of the intrahepatic vessels and diaphragm. In severe cases, sonologist cannot differentiate between the liver parenchyma, intrahepatic vessels, and the diaphragm. All will be the same at the imaging of the ultrasound. Now the fibro scan, it is a very much important tool for the diagnosis of the fatty liver, as well as fibrosis of the fibrosis of the liver. Fibroscan is an effective in predicting fatty chains and fibrosis in the non-alcoholic fatty liver disease. The CAP score is measured in decibels per meter. It ranges from 100 to 400 decibel per meter. The table below show ranges of CAP scores, and the matching statuses create an amount of fatty changes in the liver. So the CAP score ranging from the 238 to 290 decibel per meter, and status grade is S1, that is grade 1, S2, that is grade 2, and S3. And when it is 238 to 260 decibel per meter CAP score, that is status is grade is 1, and amount of the liver with fatty change is 11 to 33%. When it is 260 to 290, that is status is grade 2, and amount of the liver with fatty change is 34 to 66%. And when it is more than 90 decibel per meter, that is grade 3, and the amount of the fat is more than 67% or more. The fibrosis result is measured in kilopascal. It's normally between 2 to 6 kilopascal. The highest possible result is 75 kilopascal. Many people with liver disease have higher level than the normal range. Fibrosis score F0 to F1 means no liver scarring or mild liver scarring, and fibrosis score F2 means moderate to liver scarring, and fibrosis score F3 is severe liver scarring, and fibrosis score 4 advanced liver scarring. NFLD 2 to 7 kilopascal is F0 to F1, 7.5 to 10 kilopascal is F2, 10 to 14 kilopascal is F3, and 14 kilopascal or above is F4. CT and MRI do not reliably reflect the spectrum of the liver histology in the patients of non-alcoholic fatty liver disease, so that it should not be used routinely for determination of the fat amount or fibrosis to see the fibrosis in case of suspected non-alcoholic fatty liver disease. There are some NASH predictors: age, longer the duration of the disease, gender. Postmenopausal women have higher chance of the NASH. Race, Asian has the higher chance of NASH. Hypertension, central obesity, dyslipidemia, insulin resistance, which I've already mentioned earlier. These are the potent risk factor. If somebody have all this, he or she has the more chance to develop the non-alcoholic fatty liver disease. ALT or AST ratio more than on and low platelet level is a NASH indicator in case of cirrhosis, and persistently elevated ALT level can be associated with faster disease progression. Though there are some studies showing that there is no role of ALT level to see, but to confirm the diagnosis of the NASH, but it is a predictor. Uh, it is a predictor that show or that can assume that the patient is higher risk with the faster development of the progression to the cirrhosis of the liver. Now the treatment, first stage is the lifestyle modification, which includes dietary modification and physical activity, and there are some pharmacological therapy. The first lifestyle approach of non-alcoholic fatty liver disease, the energy restriction should be 500 to 1000 kilocalorie per day. 7 to 10% weight loss is the target, and long-term maintenance approach with that dietary and energy regulation. And coffee consumption, no liver related limitation, patient can consume the coffee. Micronutrient composition, low to moderate fat can be taken, moderate to high carbohydrate should be avoided, low carbohydrate ketogenic diets or high protein can be taken. Physiological activity, 150 to 200 minutes per week, moderate intensity in 3 to 5 sessions, and resistance training to promote musculoskeletal fitness and improve metabolic factors. And daily alcohol intake should be below 30 gram per gram for men and 20 gram per woman. Avoid fructose containing food and drink. Weight loss generally reduces hepatic steatosis, achieved either by hypocaloric diet alone or in conjunction with increased physical activity. A combination of hypocaloric diet, that is daily restriction by 500 to 1000 kilocalorie per day, and moderate intensity exercise is likely to provide the best likelihood sustaining weight loss over the time. And there are some study regarding the weight loss, and they shown that 25% cases they improve uh, the fibrosis score and the inflammation of the liver. 150 to 200 minutes per week moderate intensity in 3 to 5 sessions, which I have already mentioned. It is the standard physical activity for any kind of population, but in NFLD patient, it is the mandatory to reduce the body weight less than 75% within 3 to 6 months. Now, the pharmacological option for the non-alcoholic fatty liver disease, there are so many options has been discovered for the non-alcoholic fatty liver disease, but no one is proven or approved for the NASH or alcoholic fatty liver disease. There are some randomized control data regarding metformin, pioglitazone, liraglutide, vitamin E, omega-3 fatty acid, statins, empagliflozin, dulaglutide, ursodeoxycholic acid, and obeticholic acid, which is the most potential new treatment option is the obeticholic acid. We know metformin has so many effects on our metabolic syndrome, but does not significantly improve the liver histology. But metformin is not recommended for treating NASH in adult population. But if the patient have diabetes mellitus, metformin can be used with conjunction with the non-alcoholic fatty liver disease. And there are some study which shows the ALT and OGTT improved after in metformin therapy. And pioglitazone, which is non-diabetic and other long-term safety because of GLP-1 analog is a new hope, but it is a premature to consider GNP analog agonist to a specific treat liver disease patient with non-alcoholic fatty liver disease or NASH. Vitamin E improves the liver histology in non-diabetic adults, but it not recommended to treat the NASH in diabetic patient without liver biopsy. And omega-3 fatty acid should not be used as a specific treatment for non-alcoholic fatty liver disease or NASH until otherwise patient have hypertriglyceridemia. And statin can be used if the patient have already high blood cholesterol level, and statin can be used to treat the dyslipidemia in patient with non-alcoholic fatty liver disease, but should be avoided in advanced cirrhosis of the patient. Empagliflozin can be used. It has a good effect for improving the liver function test, especially ALT and AST levels, and it improves the liver steatosis and more importantly, measures of the liver fibrosis patient with non-alcoholic fatty liver disease without diabetes mellitus. It can be used. And dulaglutide, uh, these are the new drug, is still not recommended for the non-alcoholic fatty liver disease. Regarding ursodeoxycholic acid, there is no histological benefit over placebo in patient with non-alcoholic fatty liver disease, so it is not recommended for treatment of non-alcoholic fatty liver disease or NASH. New Hope obeticholic acid, and it has several mechanism action, and there are several studies that obeticholic acid improves the non-alcoholic fatty liver disease in regards of enzymatic improvement as well as the liver fibrosis score. There are some studies regarding the obeticholic acid in non-cirrhotic patient with NASH, and they showed there is significant improvement of the obeticholic acid at the end of the 72 weeks of the use of the Effexor or obeticholic acid. So I am almost at the end of my presentation. The conclusion is fatty liver disease is the most common liver disease in the worldwide, and estimated 25 to 30% of the people worldwide currently have non-alcoholic fatty liver disease, and 2 to 6% have non-alcoholic steatohepatitis. Bangladesh is also experiencing an increasing trend of non-alcoholic fatty liver disease due to changing dietary patterns and sedentary lifestyle. Non-alcoholic fatty liver disease is a multi-system disease, is considered the hepatic manifestation of metabolic syndrome and is tightly linked with obesity and diabetes mellitus. And researchers estimate the prevalence of NASH could increase by over 50% by 2050. Currently, no approved medication for the NASH comorbidity should be addressed effectively. Management of non-alcoholic fatty liver disease should be multidisciplinary. Many clinical trials emerging liver-directed therapy. Hopefully, obeticholic acid may be the only hope for NASH in the next few years. Thank you very much for the patient hearing. I will give my slide presentation in the comment section. If anybody need the presentation, he or she can download and study for further detailing. Thank you.